Good morning. My name is Dr. Matt Sedgley, and I'm coming to you today to speak to you on heat illness. Thank you for joining me. I am the Director of Running Medicine at MedStar Health and the co-director of Emergency Action Planning for MedStar North, with Dr. Hudson being my counterpart in the South. Today I'm going to speak to you about the management of exercise-associated heat illness. I think it's an important topic, and I want to dive into it right away here. So let's get started. First, some background. Let's think about heat and how overheating can lead to death. My background is as a sports medicine physician who works with the Baltimore Marathon, and having treated about 100,000 runners in the last few years, we have a lot of experience seeing how individuals who will overexert themselves can retain the heat they make, not be able to get rid of it. And this can lead to a spectrum of diseases that can lead to end organ damage that can be permanent and could even be deadly. If we think about how anthropologically over time, we're not the fastest creatures. Horses and dogs and other four-legged animals are much faster in a sprint. Humans, however, can run at slower paces for longer periods of time because we're designed to push off heat in our environment. However, that doesn't mean that you can't at some point overcome those accommodations that we have physiologically. People can survive heat stroke if we do the right thing, but I think it's important to realize that this can be damaging to someone permanently or even deadly when we look at overheating. Let's remember the world we live in is a hot place. I mean, if you look in 2019 in Qatar, they actually had the World Marathon run for the IAAF. They did the run at midnight because it was so hot there, and the entirety of the course was air conditioned to deal with the heat. The Tokyo Olympics that just happened recently also, very hot there. And so you may be covering a 10-miler here in Washington, D.C. in the fall. It could be a larger event, but we have to be very aware that the world we're in could pose situations where heat is a major risk factor to the health and well-being of our athletes and warfighters. I think if you think about thermodynamics, I don't want to put anyone to sleep here, but there's some important concepts that you have to have at your fingertips. And we'll start at the bottom here on this slide. Evaporative cooling is probably the one that makes the most sense for people who are actively running and exercising. We sweat, and when people are properly hydrated, they sweat, and that heat is then removed as that sweat evaporates off the skin. That's the single most important way people cool themselves while they're running. However, they also can cool themselves just by the air passing over their skin with convection. They can release the heat directly into the environment, or the body can be in contact with something colder to transfer that heat out of it. All of these are critical. However, I like to always go back to the most scientific film ever, the Titanic. If you remember in the movie Titanic, Rose, seen here on the door, is promising that she'll never let go. For those who remember, she does let go. But more importantly for our talk, really what kind of stands out here is they're both off the boat. The Titanic has sunk. Jack's in the water. Rose is on top of this door. It's cold. I mean, there's ice on her hair. Why does Jack die? Why does Rose live? And I think conduction is the answer. So when you have cold water immersion, like Jack Dawson's having here, this is a very powerful tool to remove heat from the human body. And so Jack doesn't last because his core temperature is driven down rapidly into hypothermia, whereas Rose is in the environment. She has some air going over her with convection that's cold. She is losing some heat, but she's got the life jacket on, so the heat's not directly being released as quickly. And there's not really any evaporation going on at their temperature per se, and they're probably all wet anyway, so there's no gradient. So in this case, I always like just to kind of make the joke about Titanic, but the thing that will save your runners and warfighters' lives often is finding a way to use conduction as that powerful tool to pull heat off and outside of the body. As we look at risk factors, acute illness, I think in the last few years we've all become very, very familiar with the coronavirus, but not just the coronavirus. Any illness seems to be a risk factor for heat illness. Chronic medical conditions, being overweight, which again can hold on to heat, being poorly acclimatized or dehydrated, or having genetic predispositions such as sickle cell trait, or most importantly, I think for those of us who are very familiar, a history of heat injury often portends another heat illness. And then pediatric and elderly patients, I think, are special populations we need to focus on and be prepared. If you have a race where children will be active, that's something you need to think about. How am I going to take care of them specifically, as well as the elderly? And the elderly also place us in a situation where maybe they're taking more medications. Certain medications raise that heat stroke risk. If you think about stimulants for our young athletes, someone who might just take a cold medicine with a sympathomimetic or a stimulant could raise their intrinsic heat levels, drying them out, dehydrating them. And then other medicines that are pretty common as we age, whether it's antihistamines or medicines that have anticholinergic effects that would keep us from sweating. And then remember, sweating is how we get that evaporative cooling. Neuroleptics can raise our core temperature. Beta blockers, slowing the heart rate. How are you supposed to push all that blood out to the periphery if the resting heart rate's at 40 because someone's on a beta blocker? Tricyclic antidepressants, remember they have anticholinergic effects, again anti-sweating, again impairing some of the evaporative cooling. Benzodiazepines, again, can cause confusion, can slow people down. And in calcium channel blockers, again, if you're going to try to vasodilate or chronotropically increase what the heart is doing as far as increasing the cardiac output, that's a problem. Calcium channel blockers will decrease that chronotropic output, decrease your cardiac output, and now how do I cool myself? It's very difficult. Environmental factors. Clearly, if you have yourself a playing surface, it's black and it's sunny, it's going to hold on to that heat. You have something that's a little bit cooler in the shade. Maybe you have a humid day. Remember, humidity is a problem. If I'm sweating and there's no humidity, that sweat goes through a gradient that just pulls the heat off my body. If I've got 100% humidity, because it just rained a light rain in the morning of my race or my event, okay, now I've got 100% humidity, I've got water on my arm, I can't get that gradient to work. Now I've lost one of my tools to cool myself. Wind is interesting. Wind will actually, obviously people know about wind chill, but at a certain point, you'll find that, an increased amount of wind doesn't cool. So there's a loss of that capacity over time as you increase the speed. And then obviously if you have a cloudy day, things are easier. Ambient temperature, obviously, if you're at 100 degrees and you're running, it's going to be hard to push off the heat, throwing in radiation off the body if the gradient's actually in reverse. Children and elderly athletes, I think, are a special case. You want to make sure for pediatric patients that they're well hydrated and they're well acclimatized to heat so they can be able to exercise. They're at no greater risk per se, but they compensate for having a lower number of sweat glands and lower sweat rate by usually increasing the cutaneous blood flow. And this usually will help with convective heat loss. This may be different for someone who's not a child and can sweat more. Despite this theoretical heat gain that we've always been worried about children having, it's not been clinically seen in the past. And I think that some people had reported cardiac output was an issue, but it's just turned out not to be accurate for their body size. So the key thing is, if you have children, pediatric athletes, you want to make sure if you have an event or multiple events, like you're the medical director of a baseball tournament, make sure that people are hydrated well, acclimatized well, and they have time between events, and I think they'll do well. The elderly are another group I think you have to be aware of. They may not notice that they're getting injured. They may often wear more loose or baggy clothing, affecting how they can push heat off. And of course, we've mentioned previously, as you get older, other medicines become more common, hypertension, other medications that would have side effects, anticholinergic and otherwise. So you have to be cautious with these two groups of special populations in heat. One of the things you can help, though, is just to monitor your environment. If we know that sunny days instead of cloudy days or humid days are more dangerous, following those factors pre-race is wise, and you can monitor the athlete by actually having a good core temperature. Now, professional teams have the money to do thermistor pills. You swallow them. You can scan their core temperature, but the cost is often prohibitive for most other groups. However, I find that the thing you can do the most to help with environmental issues, besides monitor the athlete and monitor the environment, is to educate. If you have an athletic director, a coach, you have parents, if you have runners in a race who know it's going to be hot, know what to do, maybe not push themselves on a recreational fun run, now you're doing a strategy that can mitigate heat. And you can see one of the strategies we use here. This is our Kestrel here. It's a wet bulb globe thermistor. There's other brands out there, and essentially what you do is you're monitoring various factors: cloud cover, wind, heat, humidity. There's actually a NOAA website that you can drag a map to and calculate without having to buy any particular wet bulb globe thermistor. I think it's fairly accurate when we actually measure it. Think about, again, heat illness. It's not all heat stroke. There's actually often a nice spectrum of the illness, and people don't come to you often with heat stroke right away. Sometimes they'll show up at your aid station at mile 10 with heat cramps, and then they do that last mile, and then they've actually got heat stroke. So there's usually kind of this dose of heat the body can't get rid of. It's making it as it's exercising. Maybe your warfighter's in a situation where the temperature has changed. It's a nice, sunny day, a little bit of cloud cover, and then it rained, and now it's humid, and now it's hot, and there's no more wind. They may come in with heat exhaustion. If you don't take them out of that situation, we could find ourselves with a heat stroke. Remember, heat stroke is life-threatening. It's actually the second leading cause of death for athletes. And we always say this is due to a core temperature of 104 with end organ damage, and typically that's from neurologic issues. Now, if you think about sudden death in the United States, whether it's collegiate or high school, heat stroke is one of our big 5 things we care the most about. Obviously, everyone's going to teach you about here today the heart with sudden cardiac death. We're going to practice head injuries, and sickle cell will be a discussion, as well as hyponatremia or low sodium. If you think about the 5 H's, that kill people, heat is usually that number 2. What's interesting, though, whether it's heart, heat, head injuries, hemoglobin issues such as sickle cell or hyponatremia, nearly all of that sport-related death is preventable. If you have an emergency action plan and you focus on at least those 5 H's, the reality is, I think most of your injuries you'll run into are preventable deaths. In general, this heat stroke has been known for centuries. It's kind of interesting. People say, well, temperature of 104, how long ago did they have that in the diagnosis? There's some evidence in the literature back to 1890s that the rectal thermometer was the best temperature, and 2, that there was actually increased organ damage after 30 minutes of not lowering that temperature. So it's been known for a while, and I think really there's some awareness. I think that if you can bring that to your team, where you're in charge as the medical director, that's going to make your life easier. You don't want to just have to throw, like we have the dog here on the ice. This is the mascot for Georgetown, where I'm a professor at in family medicine. We don't have to be dunking everyone on ice. If we can educate beforehand that this is important, you can save yourself some time and effort. Remember also, temperature at 104, key thing is actually when someone has heat stroke, it's often the time above 105, not the absolute time that matters the most when we're talking about morbidity and mortality. You know, you'd rather be like at 112 degrees for like, 3 or 4 minutes than 105 degrees for 45 minutes. So, if you can get a rectal temp and cool someone, usually within 10 minutes, 100% survive. The Falmouth road race data that I've seen, 93% of those go home, although that's a very short race, and I usually don't send people home from my marathons and ultra marathons. I think that the key thing here is, it's not the total number, it's a super high number, but it's the duration that you're above 105 that's critical. And look, heat stroke kills athletes, and it's often because there's an inaccurate temperature. Tympanic doesn't count, oral doesn't count. If it's not core, it doesn't count. And there's often delayed care, or they're using an inefficient method of cooling, or they try to immediately transport the patient, which we'll talk about here in a second. So when we talk about heat stroke, the 4 critical things that you have to do: you have to recognize it, you have to get a core temperature, and you have to cool them in the best modality you have, which cold water immersion is the superior and preferred method. And then you have to cool first before you transport. I think if you do those 4 things, you're on the team. We're doing a great job. This is what we want done. So recognize somebody. One of the things I hate is there's always some old test question somewhere saying, "Oh, the patient has dry clothes." Look, I've seen everyone who I've treated, and I've probably treated about 40 or 50 heat stroke patients in the last 20 years. They're soaking wet, but they're confused often. This is why the heat stroke, they call it a stroke because there's neurologic issues, and their core temperature elevated. So if we can recognize, get a core temp, rapidly cool, and treat first and transport second, that's the key takeaway here today. If you only remember that. Now, cold water immersion is the superior method. This is the fastest method. Although I've had people take longer in this method, if you have the ability, you can see this image. It's Dr. Doug Casa, John Jardine, who spoke with Fran O'Connor at developing the Marine Corps algorithms with us in 2018. They're at the Corey Stringer Institute. This is someone holding the head while someone else has the rectal thermistor to the left, and then other people are circulating the water. This is what you need. This is your team. This is how we want you to do it if you have available. Now, if you don't have a cold water immersion tub, you can use what we call the TARP or TACO method. This is slightly slower, but sometimes for cost and ease, this is a very effective method as well, but will be slightly slower than cold water immersion if it's the TARP version. But again, this is a completely acceptable means. Ice bags to the extremities do not do the effective cooling either enough, fast enough, and again, remember, time above 105 is dangerous to the body. They can live, but then they can have destroyed liver or brain damage. And so trying to get them down quickly is important. If you're out in the field, dousing cold water over the torso is possible. We've done that in rural settings. Rotating ice towels, again, is another possibility. Remember, the preferred way to do that is to get that conduction. You want to make your patient like Jack in the Titanic. You want that cold water to suck the heat off of them. Briefly, there is something called the Curry response. Interestingly, normothermic patients who do not have heat stroke, if you throw them in the cold water, they vasoconstrict, all their blood goes to the center of their body, and they start shivering to make heat. When you have a hyperthermic patient, there's no Curry response. Now, Curry is spelled C-U-R-R-I-E. And so that's why if you have someone in cold water immersion and they start to shiver, I don't trust that. You try to go by their core temperature, and you try to get them down to 102 before you would transport them. And sometimes you want to just kind of take them out of the water, make sure they're at 102, that they don't overshoot to hypothermia and be cold. Although some people will have underlying conditions, pneumonia, an infection, maybe they've taken some medications. We've had a runner once take cocaine. They basically will shoot back up. You'll go from 102, they'll look good, and you leave the thermistor in for a minute or two, and they've shot back up to 104, 105, 106, and they go back in the water. So When you are using the cooling methods, make sure they get down to 102, stay there, they don't overshoot too cold, or they don't shoot back up. If you do it correctly, most people will cool off in 10 to 30 minutes, although I've had some athletes and runners take 45 minutes to cool. All right, in closing, if it looks like heat stroke, treat it like heat stroke. If your rectal thermistor breaks, there's no, you have a tympanic temperature, don't use that. If you have an oral temp, don't use that. Just use clinical judgment. All temperatures should be core. Rectal thermistors are preferred. You call EMS early, but you do not transport until they're below 102. It can take some time. And remember, I feel like, Smokey the Bear here, you can prevent forest fires. You can prevent heat illness. I think it's very important to realize that we're not powerless here, and planning and starting with the end in mind is critical. Thank you. Hopefully this was helpful. If you have any questions, feel free to reach out.